Pleasure to be back and have a chance to share with you my own experience actually integrating AFOs into my surgical practice. I, contrary to what a lot of people thought or think, I actually had a very busy surgical practice up till when I retired in 2019. And I integrated AFOs into the practice very effectively as a provider of the AFO, not just implementing AFO therapy. And I want to kind of give you my perspective on this as I view trends and changes in our profession. So, what's really motivating this is my dismay and observation of a trend, particularly of younger colleagues who are referring patients out for non operative treatments, not just AFO treatments, but just about any treatment other than surgery. And I really go back to this trend where people are abandoning calling themselves podiatrists or podiatric physicians, but just refer to themselves as a foot and ankle surgeon. I really, I never referred to myself as a foot and ankle surgeon, and I certainly never wanted my patients, in terms of a referral source, to refer to me as a surgeon. Because the average patient, in my experience, if they had an ankle sprain, for example, and asked a friend or neighbor who they should go see, generally patients say, I don't want to go see a surgeon. I want to go to see someone who can fix this problem. And I had many patients come to me and say, I never wanted to see an orthopedic surgeon because all they do is surgery. And so I think using this term has a very limiting and perhaps a negative connotation. The thrust of this presentation is to really emphasize the training that you have, that I had, and that is continuing and expanding to train graduates to really be comprehensive foot and ankle specialists, not just limited to surgery. And this includes biomechanical interventions. It includes implementing diagnostic measures and coming up with appropriate diagnoses, being a problem solver, and being an educator of your patients so that they can participate in their treatment protocols. You know, our education and training enables us with the knowledge of the anatomy of the lower extremity and the understanding of biomechanics, specifically gait and muscle function, to become expert diagnosticians, really better than any other specialist. And my point is, when we take the time to watch people walk and evaluate their function, we really should be using that knowledge from the examination to provide comprehensive care, not just surgical care. Of course, you watch patients walk, don't you, when you consider doing surgery for the adult acquired flat foot? And the information you gain from gait analysis is just as applicable to surgical intervention as it is to non-operative, particularly AFO intervention. Of course, before you do any kind of major reconstructive surgery, you put the patient's joints through range of motion and you take measurements, I would hope. And those same measurements are just as applicable to the non-operative intervention as they are the surgical intervention. We put this information together in formulating a treatment plan. And when it comes to AFO treatment, you are the one that came up with the diagnosis. You are the one who took the time to do the gait evaluation and on hands joint range of motion muscle testing. Why wouldn't you be the one to properly position the patient for the AFO or even the foot orthotic based on the condition that you've diagnosed? So if you don't do AFO bracing in your practice, I'm going to give you 5 really good reasons why it would be a good thing to consider. And the first and most important is that bracing these patients is a good thing. It's good for the patient. Secondly, conservative care is mandated before any major rear foot or ankle reconstructive surgical intervention is undertaken. That's basically standard of care, and it's very good defense for you in the case something goes wrong. But as I'm going to point out, you, the surgeon, are responsible to assure that this proper conservative care has been rendered, whether you refer it out or implement it yourself. This was driven home in a very interesting article published in our Journal of Foot and Ankle Surgery in 2022. And this was a review of approximately 45 malpractice claims over a 10-year period. And these researchers at Duke University focused only on foot and ankle related malpractice claims. And they found that most of the claims involved non-operative treatment, not surgical treatment. And they said this is counterintuitive because most people think operative intervention has more risks and complications. But as they evaluated their data, they came up with the fact that non-operative treatment, while being mandated before elective surgery, failure of that non-operative treatment may in fact trigger a lawsuit. They say that it is imperative that patients who are undergoing non-operative treatment be counseled ahead of time on the possible failure of the treatment. And patients who are not counseled may be upset and angry when surgery is ultimately recommended. So the point is that non-operative treatment can be just as fragile and perhaps as volatile as operative intervention. And when you refer it out, you lose control over that. I wrote an article or a blog on this in Podiatry Today right after reading the published paper in the Journal of Foot and Ankle Surgery. And I repeated the fact that the quality of non-operative treatment, when lacking in patients and lack of informed consent about the possibility of failure of non-operative treatment, can actually lead to a lawsuit. I raised the question of what happens when you tell a patient, I'm going to refer you to somebody else for non-operative treatment, but come back and see me if you need surgery. Delegating care of your patient to someone else automatically indicates that you're losing control in a situation that may actually, down the line, trigger a malpractice suit, even if you end up doing the surgery on that patient. If the surgery goes sour, the patient begins to reflect on all of the things that led up to the surgery, including the failure of quality non-operative care. On the other hand, if you do implement AFO bracing, for example, and it works, you are in the eyes of your patient a true hero, and you get credit for this successful intervention. Take, for example, this patient, which I showed in a previous webinar, age 48 with an advanced arthritic ankle from a neglected syndesmotic sprain that he suffered while a teenager. He was fitted for our lateral arch suspender Ritchie brace to decompress the ankle joint. And after that, he was able to climb Camelback Mountain in Phoenix, Arizona, and celebrate his son's graduation from college. These types of outcomes are more gratifying than any surgical outcome in my experience. So the fifth reason to start AFO bracing is, in most cases, it pays better than surgery. It also pays better with a lot less stress and a lot more satisfaction. I wrote another blog about this, comparing payments for major reconstructive foot or rear foot and ankle surgery compared to AFO interventions. And a little later in this presentation, I'm going to discuss AFO bracing after a ruptured Achilles tendon. Medicare data from 2022, in terms of Medicare, the average payment for the primary repair of the Achilles tendon is $676. As I will show you, most of the AFO intervention pays over $1,000. But let's look at some of the procedures done for the adult acquired flat foot. And these are generous amounts based on a $60 RVU reimbursement, which many podiatrists do not get. But let's be generous and say that these procedures, starting with a triple arthrodesis at $900 and down to a cotton osteotomy of $695 and combinations thereof. This is a generous proportion for these primary procedures. But let's look at a Ritchie brace. The average Ritchie brace reimbursement is over $1,000. This is not either or. you do the Ritchie brace before the adult acquired flat foot surgery. If it doesn't work, you're not out anything. You're not replacing surgery for an AFO or vice versa. You are eligible for and should bill for and be paid for both interventions. As you know, payment for a Ritchie brace is consistent across Medicare, workers' comp, and most PPO plans, but surgical procedures vary widely depending on the contracts you sign and the plans. AFO reimbursement increases every year from Medicare. The profit from an AFO, however, should take into account the cost of the AFO to the provider. So while the Ritchie brace reimburses $1,000, it costs you $300. $700 profit still isn't too bad when you reflect back on surgical payment. Because while those surgical fees run between $900 and $600, afterward, you're working for free for approximately 4 post-op visits and at least 2 sets of post-operative x-rays. So you're donating back your time and equipment and supply expense of at least $700 after a major reconstructive rear foot surgical procedure. Finally, if we compare the stress of orthotic intervention versus surgical intervention, there's virtually no comparison. As we all know, when we have one of those dreaded post-surgical complications that keeps us up at night, it goes on day after day after day. And it's extremely rare to have such an episode occur in your practice after implementing AFO therapy. So I thought I would just take you through some of the major conditions that you see in your practice as a foot and ankle surgeon that you may not be considering AFO intervention or implementing this yourself in your own clinical practice. In our experience with the Ritchie brace, the number one diagnosis that justifies referral for a Ritchie brace is the adult acquired flat foot. And the gold standard states that these patients must be treated conservatively before rather heroic surgical intervention is undertaken, particularly in the age group that these patients present with, over the age of 50. I recently published an update, an overview, not only of the biomechanics of the adult acquired flat foot, but the literature of how orthotic intervention works out for these people. I cited over 8 prospective and retrospective studies using various types of AFOs for stage 2 and stage 3 adult acquired flat foot. And I showed that if we summarize the findings of all these studies, that 60% of patients in stage 2 adult acquired flat foot can avoid surgery with an AFO, and more importantly, can discontinue their brace 1 to 2 years after implementation. And follow up on these patients 2 to 10 years shows that they are still brace free. Many of you are unaware of these studies, and many of you are unaware that this outcome can be expected. And if you don't believe it, I challenge you to go back and read my paper published in Clinics in Podiatric Medicine and Surgery in the year 2020. We take a patient with a flexible, reducible adult acquired flat foot, place them in a standard Ritchie brace in appropriate footwear. We can expect that at least half of these patients can recover and discontinue using their brace after 1 year. Yes, they have to continue wearing custom foot orthoses and proper footwear. Yes, they still have an anatomic flat foot, but it's not pathologic because it doesn't hurt anymore. I have a whole lecture on my webinar series on the Ritchie brace website that demonstrates how to do this and how this happens. So why refer these patients out when you yourself can implement a treatment that is 60 to 70% effective? When it does succeed, you are the hero, not the referring clinician. And more importantly, even if the treatment fails, you have built the trust of this patient over many visits as they watch you attempt to try to help them. And when you finally concede that they do need to have surgery, they realize that you've tried everything first and they build a sense of trust that will carry forth into the surgical setting. When we evaluate patients with adult-acquired flat foot, the evaluation is identical, whether you're going to implement a Ritchie brace or do surgery. You must do gait analysis. You must perform joint range of motion. You must evaluate the planes of the deformity, and you must evaluate for ligament integrity. You do all of these things for an AFO and certainly must do these things for a surgical procedure plan. For example, we watch the patient walk initially to determine their level of impairment and make a decision whether immediate offloading is needed in the form of a boot or even a cast. We perform joint range of motion to classify the deformity as either flexible or rigid, and we stage the deformity 1 through 4 and pick appropriate interventions such as arthrodesis in stage 3 and 4 versus osteotomies for stage 1 and 2. Those same decisions are used to decide whether to use a fixed versus an articulated AFO or a gauntlet brace. We must look at planes of deformity, acquired forefoot supination, which indicates a need for a plantar flectory osteotomy on the medial column, but we also recognize that we must reduce that forefoot supination when scanning or casting for the Ritchie brace. We do specific tests for ligament integrity, and specifically the spring ligament. And we make decisions whether to implement an internal brace augmentation of the spring ligament, or with the AFO, whether to add a lateral flange to prevent forefoot abduction. The surgeon makes the same decisions for the surgery as they do for the AFO prescription. That is the total comprehensive foot and ankle specialist, not the isolated foot and ankle surgeon. When we implement AFO therapy or surgical procedures, the goal is repositioning the deformity and controlling rotation of the tibiofibular talar unit. The ankle foot orthosis, the Ritchie brace, is ideally designed to implement a triplane correction on this deformity, moving the calcaneopedal unit back beneath the talus. And I show how to do this in my article in Clinics in Podiatric Medicine and Surgery. It's interesting, when I was putting this lecture together, I realized that the slide that I'm showing you here originally was put together in 2014. And today I compared the reimbursement from 2014 in black font to today's reimbursement in red font. Look how much AFOs have increased in reimbursement over 10 years. The Ritchie brace went from $805 to $1,017. It's a 21% increase. I asked the surgeons in the group, what surgical procedures have been increased by Medicare over the past 10 years, let alone at a rate of 21%? The guideline basically is for flexible stage 2 deformity, we use a standard Ritchie brace. For a stage 3 deformity, we use the Ritchie brace with the medial arch suspender. We add augmentation with a medial heel skive and lateral flange. And if the patient has progressed to a stage 4 deformity, which is a rigid, non-reducible ankle and hindfoot arthrosis, we use a gauntlet. And just to remind you, we make a gauntlet that is quite unique and better, I believe, than most other gauntlets, because we implement our patented arch suspender to control the talonavicular joint. For patients who don't want to use laces, we have a continuous strap solid gauntlet brace, which we call the California AFO. These are reimbursed handsomely on the order of about $1,200 a brace. We believe that most adult-acquired flat feet can avoid gauntlet bracing with less restriction and better shoe fit using our Ritchie brace with the lateral or medial arch suspender. Using that brace for a severe collapsing flat foot can reduce the deformity while allowing the patient to ambulate freely without the restriction of a gauntlet brace. We're now going to move on to conditions where AFOs can be used pre-op and post-op. In the adult acquired flat foot, in most cases, if you have to do surgery on that patient after a failure of AFO bracing, you are changing the foot anatomically, and the custom brace that you made preoperative will not fit the foot postoperative. But there are many conditions that foot and ankle surgeons see where non-operative treatment with AFO bracing can come in very handy if the patient ends up going to surgery, where the AFO brace becomes a very effective recovery and rehabilitation tool. And I'm going to start with the lateral ankle sprain or chronic ankle instability, and then discuss tendon issues. The lateral ankle sprain is really an issue that I think is underutilized in terms of functional bracing. And as we know, the lateral ankle sprain is the most common musculoskeletal injury in sport. But what we should also recognize is we don't know how to treat it properly. Even today, the data continues to show that patients who undergo an acute lateral ankle sprain have a twofold risk of injury in the year following their initial injury because they never fully recover. Many studies show that at least 40% of patients who sustain a first-time ankle sprain go on to almost a lifetime condition labeled as chronic ankle instability. Chronic ankle instability is a complex perceptual, sensory motor, and structural deficit in the entire lower extremity chain. Chronic ankle instability is a combination of insufficient ligament healing as well as an acquired deficit in neuromuscular control. This all starts with a failure of us to recognize how long it takes ankle ligaments to heal. We're now beginning to see very comprehensive reviews published in the athletic training, orthopedic, and physical therapy literature, emphasizing that it doesn't take weeks, it doesn't take months, it may actually take years for the ankle ligaments to heal after complete disruption. These two articles point out that ligaments, regardless of the ankle, the knee, or the hip, or the wrist, have to undergo the three major phases of recovery or healing: inflammatory, proliferative, and maturation. It takes at least 3 months before the proliferative phase is even completed from the initial injury, let alone the completion of the maturation phase. Animal studies show that it basically takes 12 months for the ankle ligaments to actually achieve 80% of their pre-injury strength. The fact that patients do not ever fully heal because of return to sport too soon and lack of adequate bracing, they undergo a lifelong disability known as chronic ankle instability. So basically, athletes returning to sport should wear their brace for at least 1 year. And you might say there's not a lot of athletes that want to wear a brace for a year after a bad ankle sprain. Well, that's because the type of brace they're fitted for is off the shelf, it's uncomfortable, and it actually inhibits their performance. Yet at the same time, we know that the athlete, if they aren't properly braced, are going to be very susceptible to another injury during the first year after recovery. Even if you decide you want to repair the injured ligament, and there's some very nice technologies available today that are relatively simple and very effective to augment the rupture, particularly of the anterior talofibular ligament. We go back to this study published way back in 1985 that patients with chronic ankle instability don't always have ruptured ankle ligaments. In fact, the patients who have ruptured ankle ligaments and have chronic ankle instability are only fitting into this central part of the overlap of these circles. There are patients who have torn ankle ligaments who function very well, and there's patients with chronic ankle instability who actually have intact ligaments, but they've totally lost proprioception. To differentiate those patients, I published a paper several years ago showing guidelines for the podiatric physician in the office setting of how to differentiate mechanical instability, which requires surgery, from functional instability, which doesn't require surgery. For example, the STAR excursion balance test is an excellent in-office assessment of functional instability of the ankle that is commonly used in the athletic training arena. Repairing or reconstructing ankle ligaments without addressing functional instability will absolutely lead to failure. Bracing the unstable ankle will augment rehabilitation and ligamentous healing. The custom AFO brace can be worn during recovery, and if the patient doesn't recover and you do the internal brace or other surgical procedures, the patient can get back into their custom AFO at week 2 and not require long-term immobilization in a walking boot. The standard full flexion Ritchie brace is well accepted by athletic individuals because it allows full muscle activation, proprioceptive input, and lack of inhibition of athletic performance. It's a custom hinged AFO that allows free, unrestricted sagittal plane motion of the ankle joint while restricting unwanted frontal plane inversion, eversion, as well as internal external rotation. Because it's custom fit, it can fit into virtually every type of athletic footwear, including soccer cleats. The hinge axis is placed custom to the patient according to their own anatomy and their own anatomic axis of their ankle joint, and therefore it provides free, unrestricted motion. We have a long experience of using the standard Ritchie brace in high-level athletes, fitting well into football cleats, for example, in this NFL player for the Dallas Cowboys, who wore this brace and caught a lot of attention from the press, and wears the brace during games with tape over it, as you can see in his left ankle, tape covering a standard Ritchie brace and worn during high-level competition. We're also beginning to implement AFOs in Achilles tendon injuries. As most of you know, there's a gradual shift of standard of care of the acute rupture of the Achilles tendon to a non-operative treatment rather than immediate surgical care. For some reason, Achilles tendon ruptures are increasing in incidence all around the world. And there's a growing body of evidence that non-operative intervention gives just as good of outcome as surgical repair. The most recent systematic review and meta-analysis of studies of surgery versus non-operative intervention for the ruptured Achilles shows similar functional outcomes between both types of interventions. The only difference in some studies in higher level athletes is a significant re-rupture rate in the surgically treated, significantly lower re-rupture rate in the surgically treated group, but that's only with higher level athletes, not with relatively sedentary or moderately active middle-aged patients or senior citizens. Even whether surgical repair or non-operative treatment is implemented, the standard of care involves immobilization of the ankle into an equinus position in a walking boot, usually with stacked graduated wedges to position the ankle into equinus. More recent research has shown that locking the patient in a rigid boot actually delays tendon repair, and it almost immediately imparts atrophy of the calf musculature. This study, published in the United Kingdom, compared walking with patients in a restrictive ankle or walking boot. By the way, they measured EMG muscle activity as well as the kinematic or gait analysis inside of a standard pneumatic walking boot, as well as two different types of carbon fiber ankle foot orthoses, one with a posterior arm and one with an anterior shell. As we know, and from our own experience, and in this study, walking boots cause significant gait disturbances. They cause contralateral hip and knee pain. They disrupt balance during gait, and patients do not like wearing them. The AFO with a heel raise placed inside of the carbon fiber AFO, restored a near normal gait pattern compared to a walking boot. And they also felt that the muscle function in the leg was facilitated by the carbon AFO, uh, hopefully avoiding the common disuse atrophy we see with long-term boot immobilization. This research, as well as other papers, led me to develop our AeroSpring carbon fiber brace system for 4 different pathologies in the lower extremity, beginning with the Achilles tendon, the plantar fascia, drop foot, as well as midfoot arthritis. How does a carbon fiber AFO reduce strain in the Achilles? Well, there have been many biomechanical studies of carbon fiber AFOs and their ability compared to a walking boot to store energy. And it not only stores energy during the second rocker, but it gives an elastic recoil during the third rocker, take over for and substitute for the calf and the Achilles tendon. So these carbon AFOs reduce muscular load on the calf, and they provide an artificial push-off, sparing the Achilles tendon. So basically, using these carbon fiber braces, a lot of good things happen, including some joint range of motion of the ankle and loading of the Achilles in a favorable way to facilitate healing. So our protocol calls for, after an acute Achilles tendon rupture, immobilizing in a carbon fiber AFO inside of a shoe. A 1-inch heel raise is provided, which is gradually reduced over time of 8 to 12 weeks while the patient undergoes a functional rehabilitation program. This is a far more comfortable and functional system for the patient to wear, whether they're undergoing non-operative treatment of an Achilles rupture or surgical repair. In terms of comparing the reimbursement for a surgical repair of the Achilles is 12.2 RVUs at approximately $600. The carbon fiber AFO can reimburse as much as $1,000 depending on the region. It's not either or. We're just showing you that the AFO pays as well or better than surgery, and in many cases can be implemented along with surgery. Don't forget the dreaded insertional Achilles tendinopathy, one of the most difficult conditions to treat non-operatively, but still worth a try because you can use the carbon AFO after non-operative intervention as a recovery tool instead of immobilizing them in a walking boot. As you know, the triad includes an insertional tendinopathy, a retrocalcaneal bursa, and an insertional spur, the triad of Achilles tendinopathy. And we've actually learned from histologic studies of this spur that probably this whole condition is not due to undue traction on the Achilles, but probably due to a stress, a shear stress that occurs transversely or frontal plane at the insertion of the Achilles to the posterior aspect, setting up this spur formation, not directly due to abnormal tensile loads on the Achilles. This was borne out in this paper published at Duke University, pointing out from their cadaver studies that tensile loads on the Achilles is not the primary etiology of insertional Achilles tendinopathy, but rather stress shielding at the insertion on the posterior aspect of the Achilles tendon. Why do I point this out? Because our AeroSpring system employs a custom functional foot orthoses to control frontal plane rotation of the calcaneus, coupled with the spring-loaded system to offload the Achilles tendon directly. So we can decrease overall calf muscle activity with the brace. We can reduce shear at the Achilles insertion with the foot orthoses. And we believe this system should be used when we're intervening with shockwave or PRP treatments, which are now popular and remarkably effective as a non-operative treatment for insertional Achilles tendinopathy. And if it fails, Well, this brace can be used by week 2 postoperatively instead of putting them in a walking boot. Finally, we're just going to briefly go into tendinopathy conditions, which commonly present to the foot and ankle surgeon, and are commonly treated non-operatively, but unfortunately are treated with a walking boot. So we're using a walking boot here theoretically to offload tendons at the foot and ankle. But how many patients like to wear a walking boot for the necessary 8, 12, 16 weeks needed for some of these very chronic recurring tendinopathy conditions that I'm about to show you, particularly when it presents on the right lower extremity? How can you drive a car with a walking boot? So we really look at our biomechanical training to understand muscle function and tendon action to come up with a proper way to strategically offload specific tendons with AFO bracing. Let's start with the anterior tibial tendon. We're seeing a lot more tibialis anterior tendinopathy in practice just because the middle age and senior population are a lot more active today than they were 20 years ago. We must understand the action of the tibialis anterior, controlling or decelerating ankle joint plantar flexion the moment of heel strike, guiding the forefoot to the ground to begin the mid-stance phase of gait. I'm reminded of this interesting study published back in 2009 of a group of patients followed prospectively with tibialis anterior tendinopathy. And of the 29 patients, 27 of them were female. And certainly in my clinical experience, the majority of patients who presented to me and ultimately diagnosed with tibialis anterior tendinopathy were women. And they were definitely women over the age of 50. Now, women greatly enjoy power walking, race walking, and power walking usually involves increased stride length and definite increased plantar flexion excursion from overstriding as the foot is guided to the ground by the tibialis anterior. But the other reason women are more prone is because of their footwear. The minute a foot is positioned extremely plantar flexed in a high-heeled shoe, it places stretch and load on the tibialis anterior tendon. In this study by those authors, they recommended this provocative test to passively plantar flex and evert the ankle to load the tibialis anterior and elicit the pain. I think that's a good test to do off weight bearing, but a better test in my experience is have the patient lean against a wall and lift the forefoot off the ground. We call these heel rockers. And when they have a sore tibialis anterior, this will immediately reproduce and elicit the pain. So how are you going to treat this? Well, you're going to change their footwear. You're going to lower them in their heels, but you're also going to try to provide an external support to offload the tibialis anterior. Our dynamic assist Ritchie brace is ideally suited to decrease eccentric load on the tibialis anterior while still allowing unrestricted motion of the ankle joint during gait. This is a spring-like hinge brace normally used for drop foot, but we've learned that it's an excellent brace to offload the extensor tendons of the ankle as well as the tibialis anterior. It is worth considering custom bracing with this brace when we know the treatment's going to require 3 months or more. And in most cases, these chronic tendinopathies do require 3 months of rehabilitation and recovery. So this allows normal motion of the ankle during swing phase. It controls plantar flexion, but allows free dorsiflexion during mid-stance. So it decelerates and offloads the tibialis anterior, but it still allows normal ankle motion. This brace is reimbursed better than the Ritchie brace, about $1,300. And by the way, if you do surgical repair of the tibialis anterior, at the most you're going to get reimbursed $800. It's not either or, just showing you that the AFO braces pays as well or more than surgery. And in many cases, you're going to end up doing both interventions. Let's move laterally on the ankle to a common tendinopathy, the peroneal tendons. Keep in mind that the peroneus longus has 3 times the eversion capacity as the peroneus brevis. It's a much more important muscle in terms of transferring load and converting the forefoot into a pronatory lever arm for push-off. Patients with weak, inefficient peroneals will be observed in gait to roll off the oblique axis or the the lateral metatarsal heads during propulsion. So we know from our phasic muscle activity training that the activation of the peroneal groups is primarily during mid-stance and peaks after heel rise, just like the tibialis posterior. We're using our training in muscle activity and biomechanics not only to evaluate the patient for an AFO brace, but also for surgery. So in terminal stance, the heel is coming off the ground and the peroneus longus is firing to transfer weight medially to push off through the hallux. When it fails, the ankle is known to roll laterally. And not only does it strain the peroneal tendon, but it also places the active patient at risk for a lateral ankle sprain. Keep in mind the peroneals also have a dorsiflectory moment after they've moved the ankle into eversion. The peroneals actually assist in dorsiflexion. So to offload the peroneals, we want to maintain the ankle in a dorsiflex position as well as an everted position. Peroneal tendinopathy is usually easy to diagnose via palpation and clinical signs. Occasionally, we have to perform MR imaging. Usually, the patient presents with a mild cavus deformity and rarely with a pronated foot posture. Imaging may be necessary when surgery is contemplated, but at least in the initial decision making, MRI is not needed for AFO bracing. But what we do have to recognize is the underlying contributory deformity. And numerous studies and papers have pointed to a risk factor of a varus hindfoot and or cavus foot deformity. So we look at these patients and when we're going to consider surgery on them to repair a chronically ruptured dislocating peroneal tendon or tendinosis of either muscle group, many times surgically we decide to fix the underlying structural deformity. So we evaluate these patients for their AFO brace identical to how we would evaluate them for surgery. We do the Coleman block test where we try to determine if this is a forefoot driven pathology. Is the forefoot driving inversion of the calcaneus on this patient's left foot? Is that plantar flex first ray inverting the calcaneus? Put a block under the lateral forefoot. If the calcaneus assumes a vertical or neutral position, we know this is a forefoot driven pathology. From an AFO standpoint, we must capture this forefoot valgus deformity. And instead of a block, we balance or post the AFO in the same way the Coleman block posts the forefoot in this image to bring the calcaneus to neutral position. We can also drop the forefoot off of a block and determine the role of anterior cavus deformity and its influence on the tibia. That's an esoteric test called the Carroll test, but it isolates forefoot equinus from rear foot equinus to have decision-making surgically and for an AFO brace. With severe forefoot equinus, we want to bring the ground up to the heel with a graduated heel wedge or a heel lift, depending on the severity of the equinus determined by the Carroll block test. As we begin to lift the heel, and as we begin to let the forefoot drop off the heel lift, you will see the tibia gradually migrate anteriorly, showing the adequate level of heel lift or correction. We know that these cavus feet have a laterally displaced subtalar joint axis, and we employ surgical procedures to reposition that axis, whether it's a lateral displacement calcaneal osteotomy or a cold type procedure where we either wedge the forefoot into abduction to swing the forefoot laterally, and reposition it underneath the rear foot or subtalar joint axis. So we make surgical decision-making for patients with cavus or rear foot varus deformity the same as we do for an AFO brace. Whether we're going to perform a dorsiflexion osteotomy or capture all the forefoot valgus when we do the casting or scanning for the brace. The surgical decision making is identical to what we do with our strategy for AFO bracing. You have that knowledge. Why not use it for AFO bracing just as you are going to do with surgical intervention? Reduce the varus inversion moment of the rear foot and ankle. And we use the restricted hinge Ritchie brace using a balanced functional foot orthotic foot plate. We use posting, just like a Coleman block test, to balance out the plantar flex first ray or the anterior cavus deformity. This is the restricted hinge Ritchie brace to offload the perineals and maintain the ankle in a dorsiflex position. We add enhancements like a lateral heel skive or a medial arch flange. And here's just pictures of these. And I'm going to quickly point out, we love using medial flanges for cavus feet because it tends to pronate or abduct the foot. It pushes the foot laterally, which is a desirable outcome in taking stress off the perineal tendons. That may sound new to you, but trust me, a medial flange is one of the best orthotic enhancements to offload the perineal tendons and correct an inverted rear foot deformity. You can also add the benefit of the lateral arch suspender, which further everts the forefoot. And this is a nice enhancement for both perineal tendinopathy as well as chronic ankle instability. The uniqueness of the Ritchie brace compared to other AFOs is we balance forefoot to rear foot deformities. We balance that forefoot valgus deformity just like a Coleman block test. We can add additional posting in the foot orthotic portion of the Ritchie brace, such as varus, or in this case, a valgus sulcus wedge. We can add extrinsic posting as well. Here's a patient who's not doing well with a standard corrected foot orthosis. When we apply a sulcus wedge, which is an extended valgus lateral wedge from the midshaft of the metatarsals to the sulcus of the toes, we get a much better correction of that rear foot alignment. So, implementing AFO therapy is not that difficult to do if you're not doing it now. I've already pointed out that you as a surgeon are identifying clinical conditions, making diagnoses, and performing biomechanical exams already. What you're not doing is casting and scanning, filling out a prescription, and dispensing and fitting. All of those steps can be undertaken with any one of the Ritchie brace custom foot orthotic lab partners who provide the brace to you. We have lots of teaching tools on our Ritchie brace website in terms of how to cast and scan for the brace. If you know how to cast for a foot orthotic, you know how to cast for a Ritchie brace. We have videos and still for both plaster, for fiberglass, and for digital scanning. They're all on the Ritchie brace website. And finally, all of our distributors have well-trained staff to help you along the way with every step, including coding, billing, and reimbursement, as well as the essential steps of filling out the prescription form and taking a proper cast and scan. These authorized distributors can be found on the Ritchie brace website, www.ritchiebrace.com. They are all excellent, well-respected podiatric foot orthotic laboratory who also carry the Ritchie brace and have done so for up to 20 years. I thank you for your attention. I went a little bit over, but I'm happy to take a few minutes to take some of your questions. We'll bring Anne back onto the screen if she's there.
Yep, I'm here.
Okay.
Okay, so we have a couple questions rolling in. And before I get to those, I am just going to turn off that screen sharing so that we can see you clearly. Okay.
Okay.
All right, so let me take a look at these questions here. When do you use a prefab versus when is a casted device needed?
That's a great question. Um, I think some of those conditions, such as chronic ankle instability and tibialis anterior tendinopathy, can be addressed with. We have several prefabricated braces, including the dynamic assist, can come in a prefab version with the tamarack hinges applied. The only caution I make is if it's a Medicare patient and you dispense a prefab brace and it's not comfortable and it's not addressing the condition, and decide you want to move to a custom brace, you are now going to deal with what we call a same and similar challenge with Medicare, where they will probably deny your claim for the custom brace because you've already dispensed another AFO. Yes, it's a prefab brace, but it will fall in that category of same or similar. So that could drive your decision making, particularly in a Medicare patient.
Okay. How does, you're gonna have to bear with me. How does medial skive, S-K-I-V-E, is that a typo or a term? I'm not sure. Take pressure off perineals.
No, I went through those slides quickly. It's a medial flange. On the perineals, I specifically said to use a lateral heel skive, which provides a valgus wedge to the plantar surface of the heel cup of the orthosis. So we definitely want to perform lateral or valgus wedging to the calcaneus, but a medial flange under the arch to give more of an abductory force to the midfoot and forefoot. A medial flange will tend to abduct the forefoot and midfoot, which is desirable to offload, particularly the peroneus longus.
All right. Somebody asked if this would be available to rewatch, and I just typed in the answer, but for anybody else who's wondering that, by the end of the week, we'll have this recording up on our Academy Archives page, so you can get it there. All right, can you please review or simplify the cause of the disease pathology with retrocalcaneal spurs and which Ritchie brace to use?
Yeah, so boy, that's a. I'll quickly point out, I went into that in depth in a previous webinar I did for podiatry meetings in 2022. The title of the webinar is Offloading the Achilles Tendon with the AeroSpring Brace System. That's an entire 1 hour webinar, and at least 20 minutes of it is devoted to insertional Achilles tendinopathy. You can view that in this recorded version on the Ritchie Brace website. On the educational section of our website, we have a whole section of already pre-recorded webinars. So I encourage you to go view that webinar to get a more in-depth answer. But I'll just summarize by saying that we always thought that insertional Achilles tendinopathy was a traction phenomenon of abnormal tensile force or loading of the Achilles, literally pulling on the heel bone. But a lot of studies have been done with the histology of the spur itself, the way the stress lines go through and the calcific deposit of the spur, as well as that one cadaver study which I cited, where they found that the anterior part of the Achilles tendon, which attaches to that spur, doesn't actually develop tensile loading when the ankle is excessively dorsiflexed. And these efforts we make to stretch the Achilles with insertional Achilles spurs doesn't seem to help. It greatly helps mid-substance Achilles tendinopathy, but stretching and use of heel lifts which works well for mid-substance, doesn't work for insertional. So we're getting more indication that these insertional spurs and that whole process there is probably multiplanar. There's probably more frontal plane and shearing occurring of the Achilles across the Haglund's deformity rather than direct tensile or linear stress on the Achilles tendon itself. And so we think the aerospring system does take load off the entire Achilles, and it takes muscular strain or reduces muscle demand on the calf. But I really think combining that with the foot orthotic with a really deep heel cup can control that side to side shearing motion of the calcaneus against the Achilles tendon.
Okay, super. Can Medicare fault you for not attempting a cheaper prefab first?
Great question. You will have to, when you do your billing for the Ritchie brace or any AFO, you have to certify in your medical notes that this patient is not eligible for or would not benefit from a prefab. You have to justify to Medicare in your notes why you're moving right away to a custom device. And the criteria is you believe that the condition may last 6 months or longer, or there's a need to control the foot in 3 planes, or there's a significant deformity that would not allow this patient to be fitted properly with a standard off-the-shelf brace. So all of the reasons that you decide you don't think a prefab is going to work have to be documented in the patient's medical record. So to answer your question, yes, Medicare expects you to try a prefab unless there's certain criteria met that has compelled you, the practitioner, to go to a custom. Having said that, you don't have to do the prefab. If you in your mind feel this patient needs triplane control, has a deformity that has to be controlled in 3 planes, etc., you don't have to do the prefab. You're moving right to the custom brace.
Okay. So going back to a previous question, so no night splints for insertional Achilles tendonitis.
That's a great question. I do think a night splint, by the way, is a great intervention for an insertional Achilles tendinopathy. Because if you let that ankle hang plantar flex during sleep, it's just putting an eccentric load on that damaged tendon all night long. For the insertional spur, certainly you're not using the night splint to stretch the Achilles, because stretching the Achilles for an insertional spur really is of little value. But I can't deny that holding the ankle relatively stable in a dorsiflex position while sleeping may stop some of those other shearing motions across the Haglund's deformity and the insertional site. So I think it's really worth a try with a patient and really get their feedback in terms of whether they're getting subjective relief. I don't think it's a primary treatment in any way like plantar fasciopathy, but I wouldn't discourage its use because let me say, it is a really difficult condition to treat, and you need to bring everything to bear.
All right, so those are all of the questions that were typed into our question and answer box. If you have another question, you can certainly email Dr. Ritchie. His email address is dritchiejr, as in junior, at AOL.com, and I'm going to put that here in the chat box so you can copy it. I've also posted links in the chat for all of the previous Ritchie webinars, which are hosted on his website. And then all of our previous webinars, which are a mix of his and some of our other sponsors. So be sure to check those out. And I am going to type that email address in here real quick. Dr. Ritchie, what's next for you? Is there any shows you're going to be lecturing at or anything like that?
Yeah, the Western Foot and Ankle Conference will be at the end of June. It's a great meeting out here on the West Coast. It's the best meeting on the West Coast, and one of the few podiatry meetings that has a whole session of biomechanics. It has a whole session of sports medicine, and I'll be lecturing in the sports medicine section this year. And I always enjoy that meeting, and I encourage any and all of you to consider attending.
Awesome. We love the Western Conference. It's been a few years since we've been there because it's hard to get to California for us, but we will get back there soon, we hope. So we do have a couple other webinars coming up. As always, typically they're on Mondays. The next one is next week, Monday, May 20th. It's Dr. DeCaro talking about accurately diagnosing and effectively treating pediatric in-toe walking and toe walking. And then on June 3rd, we have Sean from Blue Orchid Marketing talking about how to promote your blank, anything in your practice, how to promote it. So be sure to check out the recordings from our previous sessions. And while you're there, sign up for our upcoming sessions. And Dr. Ritchie, thank you very much for your time this evening. Any
You're
final
welcome.
words?
No, it's always great to work with Ann and Sarah. They're always a lot of fun. They do such a great job, and I appreciate all of your support as well.
Well, thank you very much, and we will see you very soon for your next webinar.
Okay.
Take care, everyone. Good night.